Let me, with smoldering myeloma, so smoldering myeloma is in my opinion, it's not a cancer, it's a pre-cancer. And when I explain it has the ability to develop into cancer at varying rates for different individuals, but in many patients, including my father, he's okay that I say this, it will not develop into cancer, or at least hopefully not for a long time. And, when I explain smoldering myeloma to my patients, I try to explain it like a colon polyp, right? We all know what colon polyps are. You get a colonoscopy and you can have a polyp, and those have the ability to develop into cancer, but not all of them will. The only difference is with a colon polyp, we can easily resect it and eliminate the ability for that specific polyp to become a cancer. With smoldering myeloma and other precursor states in blood cancers, it's more of a difficult challenge. So I will ask any of my panelists, in today's era, off of a clinical trial, if you have a patient with smoldering myeloma who is high risk based off whatever criteria you want to use, there's unfortunately many different criteria schemas that make it confusing for physicians. Are you recommending treatment? What are you doing with the patient in front of you? They say, I want to do whatever I can to feel better and live longer. That's what they're asking for. And are you recommending treatment?
I can actually talk about this a little bit. I think when I first started seeing patients as a first-year fellow, I read the trials and I was not very convinced. I was like, this is a polyp. It doesn't need to be treated. And we can just monitor these patients, 4 to 5 months and see how they're doing and how they're progressing. However, in the latter end of my first year of fellowship, I did have a patient with smoldering myeloma who did have a tiny lesion on their bone marrow MRI. And we did not treat him, but soon he developed a fracture. And we really regretted not treating him at that stage because it is a high-risk feature. And, I think a lot of what we do is related to our practice and, what we we learn as we go. And I just thought that, since there is a 50% risk of progression at 2 years, it doesn't hurt to give somebody Revlimid for 2 years, at least if they have smoldering multiple myeloma. And, that's what we've been mainly doing in clinic. We do use the 2-20-20, but I think, any of the high risk features should at least, alarm us a little bit, and we should take it as a case-to-case basis, like I said. However, interestingly, more and more we've seen diet and exercise, improving the T cell function and improving the microbiome, inflammation in patients, and they've been studied in patients with plasma cell disorders. So I think that is something we should definitely recommend to our patients. I know that is something we recommend to everyone, in general, but I think especially to our smoldering multiple myeloma patients, it might be more important if there are some interventional exercise or dietary studies, they should also enroll in those so that we can learn more and see if, this lifestyle change could, slow their progression.
Yeah. This is where you'll see disagreement amongst physicians, and for the patients, there is no right or wrong way to do this. It's clearly a long discussion on the individual level, but I will say my 2 cents. As far as diet and what I tell my patients, in every randomized study that they've done, meaning where they take patients with whatever entity, with what they're looking for, development of cancer or progression of cancer versus, and they randomize to a dietary intervention versus just doing what they would normally do, there has never ever been shown that any dietary intervention at that level targets a specific cancer. Okay. And all the data we have right now for dietary interventions in smoldering myeloma to prevent progression is looking at what we call surrogate endpoints, which looks at changes in microbiomes or levels of proteins, but not, those are surrogates for what matters to use the patients, is like developing progressive myeloma and experiencing morbidity from that. I actually strongly discourage, we should all eat a healthy diet, do eat well, eat vegetables, exercise. But I do not want my patients to think with the current data that by doing that, they will decrease their risk of progressing to myeloma. And quality of life matters. If my patient has smoldering myeloma or MGUS and they like eating steak because that improves their quality of life, please do so. Okay. Please do so. You should eat healthy to prevent all these bad things from happening, but it's, I don't want you fixating that you can control this, or the progression of myeloma. The current data does not suggest that, in my opinion. And I would strongly discourage that. Now, as far as myeloma, many patients with smoldering myeloma will never progress. Actually, the majority, even in the new high-risk criteria, if you look at the varying data sets, and there will be prospective stuff published soon, many patients will not progress. And Revlimid is not benign. It's chemotherapy, and it's expensive, and it has side effects. Patients don't feel great on it. And I think it's just a risk-benefit talk with the patients as far as treatment. And the way I look at it is, we're getting there in smoldering myeloma. There are people or patients destined to progress, okay? And there are patients that are destined never to progress. And it's going to be based off genomic features that we're working desperately hard to figure out. So if you're one of those patients that is destined to progress to active myeloma, and you're getting treated with single agent Revlimid, we are under treating you, okay? You are getting inappropriate treatment because we treat myeloma with more than single agent Revlimid based off wonderful randomized data. If you are a patient who is not destined to progress to myeloma, you are getting overtreated, okay? So with the current data, I'm either undertreating or overtreating patients. And I just think we have to wait. I think we need to figure this out a little bit better before we jump into our treatments. Those are my 2 cents. I don't know if Dr. Phillips or anyone else has comments on that. And I want to, any questions from the audience?
Yeah, I don't treat myeloma, so I would be very ignorant to put a comment, but I do agree with you in the simple fact none of our studies have really shown diet makes a difference in outcomes for our patients, even in the lymphoma space. But yeah. I don't know the myeloma literature.
And I will say, in the lymphoma space, there are other indolent cancers that we treat, and they've done wonderful studies in CLL and other indolent lymphomas. The early treatment might make a scan look prettier, but it's not making patients feel better or live longer, and it's exposing them to therapies. And what I always tell my patients, it's very hard to make patients who feel good better. Okay.
Very easy to make them feel worse, though.
Yes. Yeah. We're very good in medicine, but a lot of we oversell. I'm not taking away anything that we do. We do miracles in oncology, but our interventions, we're in a modest gains business here. Most of our interventions are modest. And in patients with active cancer that are suffering from their cancer, those are huge benefits, sometimes those modest gains. But in healthy individuals, it is incredibly difficult to make them live longer and make better, especially in a safe fashion. So we need to be, and as a physician, if I have a patient in front of me who has metastatic pancreas cancer or acute myeloid leukemia with limited treatment options, I'm way more willing to think outside the box because the risk benefit there changes quite dramatically. But if I have a healthy patient who's feeling great, I need very strong data to recommend an intervention. Now, and this is where you'll see disagreements, but I do think the field of myeloma is getting there. They are doing wonderful studies to figure this out. I just think we have to wait a little bit longer. Oh, I just went on a rant. I apologize. So let's get some questions from the audience if there is any.